Hi, my name is Amy Horwath, and my topic is Achieving Expertise Using Simulation. I'm a critical care air transport nurse in the Minneapolis Air Force Reserve Unit. I've been a nurse for 12 years, in intensive care for the last 8. I act as a critical care air transport coach for teams throughout the Air Force Reserves and Guards, where we use low and high fidelity simulation to provide skill practice and retention. This tech talk will cover the types of simulation: low fidelity, computer-based, high fidelity, and virtual reality. I'll highlight one example as well as discuss the advantages and disadvantages of those types. I will discuss the requirements for expertise. I will cover novice through expert characteristics, discuss how a healthcare simulation can be used to gain expert level status, and finally, I will summarize the future goals of simulation development. Low fidelity simulation. This allows the user to physically move through the act of a task or skill. It does not incorporate additional real-life tactile elements, which allows for the isolation of one specific action or skill in order to emphasize it. So it can be used for a brand new skill or a skill that an individual is having a particularly difficult time mastering. Advantages of low fidelity simulation include undistracted skill development without other elements such as moving, talking patients or alarms and monitors. The learner's brain is free to learn the skill before building those other aspects in. It's easy to use. Trainers do not necessarily have to have specialized training in order to run the simulation. It's also easy for the learner to use because there are not as many features to manage simultaneously. Often low cost and low maintenance, not as many removable and replaceable parts, and not as much opportunity for technological problems that require troubleshooting. Sometimes it is the preferred method in a healthcare simulation. A study by Nimmenbacher and colleagues shows that there is no statistically significant difference in the improvement of neonatal resuscitation skills between a high fidelity and low fidelity trained group. Disadvantages include requiring additional simulation techniques in order to mimic complex lifelike scenarios. If the low simulation doesn't provide an experience that feels real, it may not be effective in transferring those skills to real situations. An example of a low fidelity simulation is an IV practice arm. It does not incorporate the entire patient body, so there's nothing like patient range of motion or discomfort to prohibit the user from angling it to themselves exactly as they want it. The skin doesn't feel a ton like skin. It will require a harder poke with the needle, same as the veins that are inside there are stiffer than real veins. So if that amount of pressure is applied to a real patient, after being learned on the IV arm, it could cause unnecessary pain. There's also no feedback for the user, such as blood return or patient response to pain. It's a good way to learn the logistics for setting up an IV, but low fidelity as far as actually starting an IV. Computer simulation. These test the understanding of a topic without physically moving through the act of a skill. It is customizable to incorporate as many additional computerized elements as desired. Advantages include more easily and widely accessible. They don't require a trainer to be there at all times in order to practice, so the individual can run through the program and get feedback from the program itself. Disadvantages include less engaging for the user sometimes, and physical skills are not improved via this method, just knowledge of the theory. An example of a computer simulation is an ACLS class online, as well as the BLS and PALS, TNCC online versions. So the screen here is what the student sees. They get the same information in a similar yet dissimilar way from what it would look like in a hospital room. The student selects the action they would like to perform. If they want to perform chest compressions, for example, they can choose that they want to do 30 chest compressions, is 2.5 inches deep at a rate of 100 a minute. But saying you want to do something and doing them are two different things. And there's no assessment or feedback of the student's ability to perform that skill the way they say they would. This is a much more accessible way for healthcare providers to maintain their certifications. They can do it more at their leisure, and the completion time does not rely on the learning speed and skills of the other people in the class as it would in an in-person setting. High fidelity simulation. This again allows the user to physically move through the act of a task or a skill. It incorporates many real-life tactile elements which better replicates an authentic scenario. Advantages of high-fidelity simulation include the complex lifelike scenarios, which make it easier to transfer skills to real patients. And the user is learning to navigate distractions. Disadvantages include that the cost is often higher than low fidelity, often requires more maintenance and replacements. There are more parts. Additional training for the trainers, possibly even additional simulation dedicated staff. An example of high fidelity simulation is the Laerdal-Sinman 3G. He is a full body, all joints can be moved, he can talk, cry, blink, breathe, has breath sounds and chest rise, he can bleed, urinate, have fluids running through his veins, have chest tubes inserted. He provides feedback via a monitor for vital signs, or some things through the mannequin like pupil reactions. Those are changed at the discretion of the trainer. Yet he cannot feel pain. And here you can see some of the inner workings, so a lot of tubes and parts that could come apart, break. They require cleaning to maintain patency, so it makes them a bit more high maintenance compared to the low fidelity example. Virtual reality simulation. This allows for physical completion of a task. It is customizable to incorporate real-life tactile elements as desired. Advantages of virtual reality simulation include that it simulates a complex lifelike scenario. It has more sensitive error detection than the human eye. So for example, it can sense if a scalpel hits something it's not supposed to inside a body cavity better than a trainer or evaluator could. You can add forced complications, such as uncontrolled bleeding or other problems, forcing the user to learn to handle specific complications before they happen in real life. And then Health Tech magazine asserts that VR trainers cost less than high-fidelity trainers. Disadvantages to virtual reality simulation include that it requires a lot of training of the trainer. Not all of them have a physical patient simulator to provide the resistance one would feel in a real body. And they do still cost more than low fidelity trainers. My example for the virtual reality simulation is a program called Surgical Navigation Advanced Platform, or SNAP. It's a neurosurgery trainer. So here you can see the surgeon wears the virtual reality headset and has controllers in his hands that mimic his normal surgical instruments. The controller's place in space is picked up on the program and projected into this image. So here you can see he's not using a SimMan or other tissue-like substance he's actually having to cut through. But there are other surgical trainers, such as Top Gun laparoscopic skills trainer, that do incorporate more of those elements. This one here, the SNAP, allows specific patient scans to be used to create a virtual scenario that is identical to the patient's brain, and the surgeon walks through it on the trainer before performing actual surgery. Simulation implications. So why do we care about simulation, specifically in healthcare? Our number one concern always in healthcare, patient safety. There's financial considerations, there's confidence, and then as I'm going to discuss in a later section of this presentation, simulation can cut the time it takes for a novice to become an expert. Patient safety. According to the WHO, 1 in 10 patients are harmed receiving hospital care. So that's 400,000 patients per year that experience preventable harm. Johns Hopkins estimates over 161,000 preventable deaths per year. It's unsafe and unethical to use living patients as practice subjects when other methods are available. Creates unnecessary risk to use real patients until a certain level of skill has been obtained. There are ethical considerations such as our commitment to doing no harm. Fiscal considerations. According to the WHO, Medicare hospitals saved over $20 billion in a 5-year period by investing in safety measures. That would include skill simulation. Preventable healthcare errors cost $20 billion every year in the U.S. There are also financial costs to patients and families. When a patient's stay is prolonged due to a preventable error, there are additional lost wages of the patient and often one or more family members. There can be additional childcare costs. Families who live far from the hospital would have additional travel and hotel costs. And then in the cases of preventable deaths, that's potentially one less income those families have, not just during their hospitalization, but for life. So confidence of the healthcare provider is built with more practice. Simulation creates an environment where it is safe to make mistakes and therefore learn from their mistakes. It's hard to ensure that during a residency, complications will occur in real patients, plus the ethical implications of having a novice potentially cause undue harm by being the one to handle a complication they've never seen before. But if the learner can practice problem solving through complications before they happen in real life, they'll come away with some experiences to lean on when they happen to a real patient. Confidence of the patient in the healthcare provider, because the healthcare provider will walk in looking and acting more confident, will be smoother in performing the tasks, and that will leave the patient more at ease. It's widely accepted that patient perception is a key component to whether or not they sue a doctor for errors, so we want them to be confident that we are practiced in our trade. The Dreyfus model lays out 5 stages of skill achievement. Number 1, novice, 2, advanced beginner, 3, competent, 4, proficient, and 5, expert or master. The novice and advanced beginners, they require instruction and feedback pretty much all the time. They have no decision-making ability, rely on rules and guidelines that are laid out by their superiors. These are the people that will benefit from low-fidelity simulation because they can focus on one specific isolated skill until they have some muscle memory and can perform it without being walked through it. The competent learner is able to perform simple tasks independently, requires less instruction than the novice, but does require instruction for complex tasks. They're not ready to be independent without the backup available. They have limited decision-making ability because they have a limited number of experiences to draw from. Competent learner starts to have routines by deliberate planning. They're no longer following the rules line by line, but rather creating their own practice within the set of guidelines. For example, an OR tech might start having preferences to how they like their table set up with the instruments that are required by the surgeon or protocols. Proficient learners, they are independent with complex skills. may seek instruction at times, but usually after attempting to problem solve independently. The proficient learner has enough experience to rely on when responding to situations. They can foresee potential deviations from the plan, and they start to think through solutions ahead of time. And the expert learner, or the master. The expert relies on intuition to respond to situation. Their skills are second nature. They create new ways of solving problems by using an analytical approach to new situations instead of seeking out instructions from others. But it is important to note that experts do still seek out guidance from others, but more as a learning opportunity than as a need to solve a problem in real time, because they're capable of effectively solving that problem faster than finding assistance. So how does one become an expert? Malcolm Gladwell's 10,000 hours theory is well known and widely discussed. The difficulty level of a skill has been broadly accepted as a variable to that number of hours, and discussion around genetic affinity for a skill is another common topic. However, there's no exact number of hours or exact number of times one can perform a task or skill that guarantees mastery. But definitely the more you perform something, the better you are. So as I mentioned earlier, simulation can make a novice an expert in less time. So it can provide more hours of practice for a larger number of people in a shorter amount of time. You don't have to wait for a gunshot wound to come through the ER to practice removing foreign bodies. You can use a simulator, practice, stick the bullet back in, let your three other friends practice on the same guy, and then do it all again tomorrow without causing any pain to a real human. Once an expert, not always an expert. So you must continue to regularly practice skills to be able to perform them at an expert level. As healthcare providers move up in their career fields, especially in the military, they are often tasked with more and more additional duties that may leave less time for direct patient care. Simulation can help bridge that gap. It's important to know that all levels of learning from novice to expert, simulation is not a substitute for, but rather an adjunct to performing skills on real-life patients. So simulation can provide a lot of practice in a short amount of time, but as we have discussed in the disadvantages of each type of simulation, none of them are 100% realistic. So real-life skill performance must be accomplished before expertise or even advanced beginner level status is achieved. The future of simulation technologies. Out with the old, in with the new. Specific medical simulation technologies may become obsolete and replaced by more sophisticated ones. Some may be updated to avoid being completely replaced. But as they continue to develop, simulation trainers will more closely mimic real-life situations. They will have a wider scope of use. Virtual reality simulations right now are highly focused on surgery, but they could definitely be used for other healthcare professionals. Nurses could learn dressing changes or IV starts. RTs could practice ABG collections. Physical and occupational therapists could work on many of their skills using virtual reality technologies. With the literature supporting VR as a cheaper, more accessible option than high-fidelity mannequins, I believe virtual reality will be much more prominent in the future of healthcare simulation. So advancements in simulation technologies, as they continue to develop, they will more closely mimic real life. Skin will feel more like skin, veins will feel more like veins. Perhaps the mannequins will move their limbs on their own. Increasing cloud-based training technologies make simulation accessible from anywhere at any time. And then 3D printing to replace parts or create parts to meet specific needs of the facility would be cheaper or faster than ordering from the manufacturer. So if you needed a heart model or a little plastic piece broke off your sim man, potentially you'd be able to replace it on your own. Advancements in medical technologies. So more and more robots are being created to use in healthcare. We've had the Da Vinci for a while now. We're getting these pharmacy robots that will deliver medicine to you on the unit, clean rooms, all sorts of other things. We also have advancements in the current tools, so upgrades to cardiac stents. We have improved prosthetic limbs. But when a medical device company makes an advancement on a product or develops a new product, healthcare professionals will need to be trained using these technologies before it is used on a patient for obvious safety and ethical reasons. So simulation plays a great role in these situations. To trial a new surgical implant, for example, virtual reality allows surgeons to practice new techniques without using multiple cadavers. The future is going to add more emphasis on the assessment and feedback of the learner. So we will be seeing more defined metrics for assessment and the ability to build those into the technologies for simulation, especially as technology becomes more sensitive to user movements. So right now, the sim man's vital signs change based on what the instructor plugs in. The future may see a sim man that is sensitive enough to pick up that their artery was nicked while starting a line, and the blood pressure might automatically decrease appropriately without instructor intervention. The future of simulation costs. More products being available drives down the cost of the technologies. In recent years, healthcare has shown an increase in education budgets. This makes it look like there's more money available for cheaper items, but these technologies require personnel to run and maintain. Plus, the emphasis on more hours of training requires higher staffing to support. So it is yet undetermined if healthcare is spending more or less, and if they're getting more or less simulation for that price. The future of simulation is dependent on healthcare administrators accepting that spending a significant amount of money upfront on simulation is cost effective by preventing medical errors that cost much more. Simulation saves money and lives. Thank you for listening to my Tech Talk.